I'm Rebecca with 1C, and this is Silent Crash. Today, I had intended to share with you some of the backstory we've uncovered that led to Public Acts 21 and 22, the auto no-fault reform in Michigan. That research includes money and relationships that have been flowing for decades, but which turned their focus in earnest just 5 years ago toward destroying auto no-fault in Michigan. That information involves the Republican leaders who led the charge for PA 21 and 22 and who are blocking its reform as I speak. However, while I put that episode together for you, my inbox became flooded with information and thoughts about an auto no-fault reform bill introduced in the House earlier this week, HB 5698. Some say it is the fix that everyone is waiting for. Others say the opposite. If you've been here longer than a minute, you know that my penchant is to simply go to the heart of the matter, to its source. So, I called up the person who wrote this bill.
Yep, I'm State Representative Phil Green from the 84th District, which is Huron and Tuscola County in the thumb of Michigan. This has been a passion of mine. The auto no-fault bill has been a passion of mine as I have some constituents that are impacted, but as well, shortly after my mom had a stroke in 2011, she was put in a rehab facility called the Lighthouse in Carroll that services brain-injured people, many of them through the auto accidents. And so she was a recipient of unbelievable care because of the research that was done at this facility for brain-injured people. And so this has been a passion of mine, let alone the healthcare side of it. My wife is a registered nurse. And so understanding the care for people as well as how that care gets paid for.
So before you got to the House, tell me about your life before that.
So I grew up in a Christian home, and that was it was expected that we were going to serve. We're going to serve each other. We're going to serve our community, and just those values. My dad was in the state legislature. He retired from General Motors after 28 years, I think it was, that he retired from working in the General Motors factory, and was involved in our Christian school, involved in the battles of keeping the state out of our Christian schools, and then got elected as a county commissioner, a state representative, and the state senator. And so it was just given that we were going to serve. I went to college at Pensacola Christian College to serve as a youth pastor at churches. So I have a degree in Bible youth ministry, have a master's degree in biblical exposition, and then I'm in the middle of 2 doctorates. So I went from Pensacola, met my wife there, who is a registered nurse, and we moved to Oshkosh, Wisconsin, where I was a youth pastor, and then got involved in chaplaincy for our sheriff's office. Was there for about 4 years, moved out to Western New York, halfway between Rochester and Buffalo, so near Niagara Falls, and started a chaplaincy program there inside the sheriff's office, and working with the deputies and helping them through different issues. I was certified in CISD, critical incident stress debriefing, as well as PTSD. And in 2011, I received the National Sheriff's Association Chaplain of the Year Award. Also in 2011, my mom had a stroke. And so I moved my family. I realized my wife grew up in Virginia Beach. Her dad is a retired officer, commander in the Navy. And so we were about a 12-hour drive from her family and about a 6-hour drive from my family. And when my mom had the stroke, we did some soul searching. And we realized that when life hits the fan, as it does, the people who really stand beside you are your family. And so we wanted our children to get to know their cousins and their grandparents in a very tight way. And in 2012, we moved back to Michigan. I became the Christian school administrator and assistant pastor at a church in Vassar that I grew up in, that I graduated from. And was the assistant pastor for about 6 years when the position of state representative opened up because of term limits. And so after consideration, we felt that this was one of our next steps, my wife and I, to be able to continue to serve our community and to help individuals that need help in a same capacity as a pastor, but just in a little different focus.
So when you, as we've talked about here on this show, lots of the Republican leadership seems to be pretty reticent to address the issues that are coming about as a result of PA 21 and 22 being implemented as of July last year. And yet you've stepped up and said, let me see what I can do here. And so I'm just wondering what was it that made you step away a little bit from your leadership and say, no, we really do need to do a fix here, and go so far as to draft a bill to do it?
Well, so again, committed to service, right? And my background is human services. I've taken drug addicts and taken them to rehab. I've picked them up from their house and call them and say, hey, look, rehab is tonight. Let's get in the car. You're going with me. I've worked with sheriff's deputies. One of the things I did as a sheriff's chaplain was death notifications. So I have a very real sense of what people are going through. Visiting people at hospitals and trying to help them through whatever issues they have. Maybe they, in New York, especially as the pastor there, maybe they can't come home because they can't take the 3 steps they need to get through the doorway at their house. And so the PT, the OT issues, those are things that I'm very well aware of. So maybe I'm more focused on the human element because that is my background. Whereas others in the Republican world have come from a business background, or they've come from a consumer background. And that's the human element just maybe isn't one of their focuses, if I can defend them in that capacity.
Right. So talk to me then from that human element perspective. In your bill is HB 5698, and it was introduced just this week, right?
Correct.
Okay. And I understand you have 57 co-sponsors. Is that right?
That is correct. I have 57 co-sponsors plus me. That means there's 58 of us that have put our name on a line that says this is a bill that we will vote for. Mind you, there are 110 legislators in the House. So therefore, if you have to have 50% plus one, a majority, to vote for something to pass, you need 56 yeses. So basically, I have on record, unless things change, which they do with bills, I have on record that there will be a minimum of 58 yeses.
Now, the journey of a bill becoming a law is multi-step. For a bill to become a law in the state of Michigan, it is introduced in either the House or the Senate. The bill is then referred to a committee focused on that bill's subject matter. Representative Green's bill has been referred to the House Insurance Committee. Typically, the committee will then hold hearings on the bill. The public, experts, and affected citizens can testify in those hearings, and committee members can ask questions and put their own opinions about it on the record. The idea is for the elected officials to hear from everyone and then edit the bill to be better than it was when it got referred to the committee. The committee then votes their amended version of the bill back into the main chamber from which it originated. In the case of HB 5698, that's the House. The House then has a second reading of the bill, thereby informing all members of the revised version of the bill. Sometimes amendments are proposed and voted on after this second reading. Once all the changing is done, the bill is read a third time and the House votes. That's when you see the board on the wall light up and members voting green for yes and red for no. But remember that the bill has to pass both the House and the Senate before it can go to the governor for signature. Now, the Senate can either be moving a similar bill through its chambers while the House is doing its thing and they'll just reconcile at the end, or it can wait to receive the passed House bill, and then it creates a Senate bill that mirrors that House bill. And then the Senate's bill has to go through all that same process, the reading, the committee, the second reading, the third reading. If the bill changes, even by a comma or a period on the Senate side, then the bill must go back to the House, and the revised version must be approved. Now, once both chambers have passed the exact same bill on third reading in each of their chambers, the legislation goes to the governor, who can either sign it into law or veto it. So far, all bills introduced to address the problems of PA 21 and 22 have died in committee. But Representative Green notes that there is a way to circumvent the committee step.
There are processes where the Speaker of the House and the Majority Leader in the Senate, there are legitimate processes where they could discharge a bill straight from committee and not have committee hearings, discharge it straight to the floor, and then we could vote on it. And that is a very legit process. It's just not maybe the spirit of the process that we want, especially when we are against a bill. When we're against a bill, we want it to go through the whole process so there's more time for us to kill the bill. When we are for the bill, we want that process to happen. We want it discharged straight from committee and come on. So I am advocating personally for 5698 to have that expedited process. Skip the hearings, bring it to the floor. We got the votes, vote it.
That would make sense given that you have so many co-sponsors. It's very clearly the will of the House that this bill get passed because you have a majority of members of the House co-sponsoring it, right?
Correct.
In drafting this bill, have you incorporated feedback from the stakeholders like what would happen in a hearing in committee? Have you talked to home health care agencies and that sort of thing?
Absolutely. I've gone through 5 drafts before we created the actual bill that was dropped. Now, the one thing that I've worked with the agencies, the Home Health and Hospice Agency. I've worked with the Hospital Association. I've worked with different organizations that have an interest in it. But what I did was I also went to individual home health agencies that maybe don't even deal in the auto no fault world. They don't have any patients that are auto no fault patients. And I went to them and I said, here is my plan. Agencies that deal in auto no fault, that have those patients, have helped me write this. I want to be fair and just for everybody. I don't want people to gouge the system. You do not play in this world. Are these reimbursements fair and just? So I went maybe a step beyond what many do, just making sure that what I was proposing was not way out of whack and an opportunity to defraud the system by overcharging the system.
So are you of the mindset that there was rampant fraud coming from the catastrophic car accident community in the system?
I am not of the opinion there was rampant fraud. However, we know from systems across any agency, across any part of life, there is generally about 3 to 4% fraud. Whether it's in tax filings, whether it's in whatever. I am not of the opinion that there was rampant fraud. Were there maybe some things that should have been done differently, or people fudged the system, you know, more than likely there probably was. And I think that needed to be fixed if that was an issue. But to go after the whole industry because of 3 to 4% fraud is vindictive, as well as just not wise and prudent.
Can I just ask on the note, and I do want to get into the guts of what's in your bill. I do want us to go there and talk about a few details, but based on what you just said, we've had a lot of feedback from listeners saying, number one, they agree with you that there wasn't rampant fraud, and there does not appear to be, as much as we've been able to uncover, and even as much as the insurance lobbyist agency, the IAM, has been able to put out. There is no evidence for rampant fraud from the catastrophic car accident community and their providers. And so the question keeps popping up, why is there not just a repeal of PA 21 and 22 and then an effort made to create a bill that actually works and doesn't have all of these negative ramifications that we're seeing in patient lives up to and including death? So, or at the very least, another listener has asked, why is there not just a moratorium on the implementation while they review it, now that they can see the unintended negative consequences of it? And so as an elected official, has that even been a conversation or an idea? And if not, why not?
Well, I think the question comes up to viable options. So there's 110 of us. We have to agree, at least 56 of us have to agree. And then even inside of that, many times they call it the Hastert rule, the Dennis Hastert, the former Speaker of the House in Congress, that said his rule was that he would not push a bill that did not have more than half of his caucus's support. Okay, so there's some maneuvering inside of that. So a full repeal, is that going to be possible? Is it going to be, we can introduce it and individuals have, but what is actually going to be able to get done? The opposition to a full repeal would be enormous. And so the question then comes, sure, let's do a full repeal and let's just tighten up the areas that need to be tightened. Would there be enough support for that? And the answer is, across the board, I do not believe that there would be enough support to completely repeal every aspect of that bill. So then we move forward and we say, what can we get? What can we get to maintain the integrity of wanting to stop the fraud, as well as wanting to make sure that we are reimbursing our caregivers appropriately? And so that's where this came out, is what can we get out of it? And not only that, is were there some good elements of reform? I think there were. Some elements of the reform were actually relatively okay. So trying to maintain the spirit of what was done. There's some stuff on the that we reformed in regards to allowing for, not allowing for, but requiring rapid pay. It's been very widely known of the deny, delay, and then settle tactics of the insurance companies. And so they would just string out a claim for 180, 270 days and then say, well, look, how about if we just settled for 75% of this? And so there's a provision in the bill for rapid pay. There's a provision in the bill that talks with the insurance companies about the types of the requirements for people that they can use to serve as IMEs, independent doctors that the insurance companies use to deny those claims, so that we put some requirements in there. There are possibly some other things that, I'm a proponent of choice. I'm a proponent of people in Michigan should have a choice as to what they purchase. And so I think there could be a philosophical discussion made for allowing people to choose the level of insurance that they purchase instead of requiring everybody to purchase an unlimited umbrella policy. So there are some things there that I think from a conservative Republican standpoint, you say, you know what? I understand giving people a choice. We may not like their choice. Maybe they would choose to opt out of the whole plan, but that would be their choice. So I think maybe philosophically there's some positives.
So the individuals that would opt out of unlimited coverage at this point, and both parties say this, are on the record as saying this, are parties that can't afford unlimited coverage. And so my question to you would be, is that really a choice? If it really is only a choice to people who could afford to say yes or no, did you really give a choice to, say, the single mom who's trying to put food on the table for her 5-year-old and can't afford unlimited coverage? So she can't afford to say yes anyway. She had to say yes prior to the reform because that was the law. And now she says no, not because she doesn't want unlimited coverage, but because she can't afford unlimited coverage. So is that a choice?
That is a great question of how, when things filter themselves down to where we actually live, I call it out of the ivory towers and into where we actually live, where we debate stuff in the perfect world in the ivory towers, and then you get down to where we actually live. I don't have a good answer for that. I really don't. The ultimatum was we require them to purchase something that they can't afford. So that was the arguments that are made.
The idea, of course, being if she's in an accident, she certainly can't afford lifetime care if she couldn't even afford unlimited coverage. The idea behind forcing everyone so that no one ends up medically bankrupt and on Medicaid.
Let's take a short break here. When we come back, Representative Green and I delve into the details of his bill, specifically whether it addresses the 45% cut in pay and massive cut in friends and family attendant hours. I'm Rebecca with 1C, and you're listening to Silent Crash. Welcome back to Silent Crash. I'm Rebecca with 1C, and I'm talking with Representative Phil Green of the Michigan House of Representatives. Representative Green's bill, HB 5698, was introduced earlier this week and seeks to address some of the more problematic elements of Public Acts 21 and 22, the auto no-fault reform. Let's get back to the discussion.
So let me switch gears a little bit to what's actually in your bill, because two of the elements from the reform that we've covered extensively here on the show are, number one, the cut in pay to only paying 55% of what someone charged in 2019. And I'm not sure if you're aware, but some of the feedback that we've been getting is that's not actually how it's being implemented. Many are not even getting 55%. And if they do, it's not 55% of what they charged. It's 55% of what they were actually paid in 2019, which you know as well as I do that oftentimes what you charge is not what the insurance company agrees to pay. And so with regard to the 55%, does your bill address that cut in pay in any way?
Yes, it does. That is maybe the meat of the bill. Many of us as human beings, as individuals, do not fully understand nor comprehend how our healthcare system works and how health insurance works. We equate it to things that we know. And so the best way to explain that is I believe many of us think that our healthcare They believe, they don't, it's not truth, but they believe our health care is like a grocery store. We walk in, we buy a broken arm, we buy an MRI, and we buy a CAT scan, and it costs $5,000. And then the person behind us walks in and they buy a broken arm, a CAT scan, and an MRI, and it costs them $5,000. When in reality, that is not how our healthcare system works. We have multiple payers. So you have commercial insurance, and each commercial insurance, whether it's Blue Cross or HAP or Molina, or I mean, you go on down the list of the commercial payers, the commercial insurers, they each have contracts with healthcare systems. They say, look, that broken arm costs you $500. We will pay $450 for it. Or maybe we'll pay $600. They have a contract price. A cardiac cath costs this much. We'll negotiate a price. So that is the commercial insurers. But there's a whole nother group. The whole other group is called Medicare. And Medicare says there's some bureaucrat in Washington, D.C. that says, okay, there are 10 regions in Michigan, and they're all a little bit different. So we are going to decide in Washington, D.C., how much it costs for healthcare in each of those 10 regions in Michigan. And so we are going to tell them that they are going to get 100% of their cost paid, plus 1%, minus 2% for administrative charges. So for each Medicare patient, some bureaucrat in Washington, D.C. has determined how much they will pay for each procedure, and that's just the way it is. There is no negotiation. In fact, for 3 years, the Medicare can, the healthcare provider can call Medicare and say, look, I have X patient and he needs this procedure, and they give a prior authorization. And they say, okay, yep, that's covered. Go ahead and do it. Here's your prior authorization number. 3 years later, up to 3 years later, they can come back and say, well, you know what? We shouldn't have given you that prior authorization. So we're going to claw back the money we gave you for that procedure. So the healthcare system is not the same as a grocery store. This is anybody who deals with Medicare. I'm speaking specifically of my knowledge with hospitals. Okay. So, but anybody who deals with Medicare, there's a 3-year clawback, even if they're prior authorized to do it. So we have a commercial pay, we have the Medicare, and so we as people believe that if I have a broken arm, it shouldn't cost me more if I'm on Medicare than if I'm on commercial pay, right? Commercial insurance. But that's not how things are done, okay? So when we apply that to auto no fault, we talk about what do my colleagues believe happens, right? And that is the struggle of trying to explain that the healthcare industry is not a normal retail industry, okay? So when this portion was negotiated, there were a group of individuals from the hospital industry that negotiated this portion of it. And the individuals from the post-acute, the home health and the rehab facilities, long-term nursing care facilities, were not part of the negotiations. So they came to a conclusion with the hospitals that 200% of Medicare, or 215% if you are a level 1 trauma center, or I believe the other tier was 190%. But a fee schedule based off of Medicare is going to be appropriate. And then whatever codes that we have that aren't covered, whatever costs that we have that aren't covered in Medicare, a 55% of what our charge master is comparable to 200% of Medicare. So that works in the hospital world. About 95% of their codes are covered in Medicare, and 5% are not. So it works. But the post-acute side is the exact opposite. About 5% of their codes are in Medicare, and 95% are not. And so with about 95% of their charges, they were being reimbursed at 55% of their 2019 charge master. The assumption was that they were overcharging, okay? When that may or may not have been the case. The assumption was that there was rampant fraud, but the reality
Has anybody looked into that to see if they actually were overcharging?
Well, in a free enterprise world, you can charge whatever you want. In the healthcare world, though, the issue is not what are you charging. The issue is how much are you being paid. So you send a bill to your insurance company, and what they actually pay is different than what you charge based upon their contracts, based upon any number of factors, right? And as we have gotten into it, the light is being shed on what is actually happening inside of the healthcare world, in that we are sending in a bill for $200, and here's the code for it. Well, we are not going to reimburse you at 55%. We're going to reimburse you at some other number that we decide is there. I mentioned to you earlier that I was pastor of a church. And there are, in leadership and as well as in church, there are 3 basic rules, right? Rule number 1 is the golden rule. Do unto others as you would have them do unto you. Rule number 2 is the platinum rule, which says, do unto others as they would have done to them. So learn about the person and give them a gift that is important to them. The third rule is a little bit tongue-in-cheek. It's called the gold rule. And the rule is, he who has the gold rules. And in the healthcare world, the person with the gold, the entity with the gold, is the insurance company, because our system inside of America, whether it's hospitalization or whatever, is either, you are required to buy insurance. So there has to be a working relationship between the insured, the people, the insurance companies, as well as the people who are doing the work. I use the letter P. There is the payer, which is the insurance company. There is the provider, which is the health company. And there is the patient, that is the person that has the work done to them. So there has to be a working relationship between all 3 of those P's: the provider, the patient, and the payer. So the meat of this bill is that 200% of Medicare, and then it goes straight to a 55% cut. What this bill does is it creates a cascade effect. If it's not in Medicare, is it inside of the brain injury waiver program that is part of DHHS? So there's a lot of codes inside that brain injury waiver program for OT, PT, VT, the therapies, as well as a per diem rate. So if the code is there, then use it. If the code is not there, then it cascades into the 150% of the VA program. And so then if there are charges that a company has that is not part of the VA program, then it would hit the 55% cut. So That is really the meat of the bill.
So it starts with use a Medicare code. If there's not a Medicare code, then use what?
Let me rephrase how I did it. That was my original plan. How it actually came out in the bill is 200% of Medicare. If it is not in Medicare, the services rendered in a post-acute rehab facility would be subject to a 200% of the brain injury waiver program. Secondly, for those services rendered in a person's home, they would be subject to 150% of the VA schedule, the Veterans Affairs schedule.
And then if it didn't fall under the Medicare program or a Medicare code, and there also was not a VA code, then what happens?
Then it would be subject to the 55% of the charge master.
And what is the reasoning behind still having, under what I'm hearing you say, there really shouldn't be any instance that falls under the 55%, but as we've learned, there can be unintended consequences and things not thought of. So what is the reasoning behind even keeping such a steep cut in the law?
Number one, I believe it maintains the integrity of the law, okay, of the intended consequences. But I think also we go back to the question previous, which was, why don't we just repeal the whole thing? And so it comes down to many individuals that worked on this bill felt that 55% rule was a just compromise. And so if I were to remove it from the bill, it would put a lot of human beings of the 110 in the House in a very uneasy situation where they may not vote for the bill. So to maintain the integrity of the deal that was made, we're going to leave that in there. But then as well, it also helps to say we are not trying, as we look at the individuals who worked on this bill and are very attached to the PA 21 of 2019, I have to get their support on the bill. I need their vote. And if I were to look at them and tell them, you did a horrible, very bad, no good job, I'm not going to get their vote.
Is it true that if I'm a friends and family person serving as that home health attendant, according to your bill, the intent of your bill would be that if I'm a mom and I've quit my job and I'm the one at home rendering care to my daughter, then my hours would be coded according to a code in the VA schedule as a home health attendant. Is that right?
That is my intent.
Got it. And so then let's talk about that scenario too, because in PA 21, that cut my hours as a mom from what was previously unlimited down to 56. Does it stay 56 in your bill?
In my bill, so 56 is 7 days a week, 8 hours a day, okay? A full-time plus job. What my bill does is says that a patient would be available for 112 hours of family attendant care per week. So it would double the number of hours for family attendant care available for that. So it is not based on the number 56 and 112 is not based on how many hours mom can provide. It is based on the number of hours that the patient can have family attendant care. So whether or not you believe it, we'll put that aside. Stories are told from very credible sources, not insurance companies, okay, of A catastrophically injured patient that needs family attendant care would have his and anybody who's a family member, his mom, his dad, his brother, his sister, his cousins, would all be approved for family attendant care. And anytime they walked in the door, they would write it down as, I did that. I worked on it. And so they would get paid every time they came over and visited their loved one. And so the idea would be is, whether or not that's true, I don't know. Okay. That is an example of that people use, and that did not come from an insurance company. Okay. So it comes from, in my opinion, a reputable source. So what it would do is say, look, you can charge all that. Cousin Billy comes by to say hi and charges for a 15-minute visit. You can charge that still. But the patient is only allowed 56 hours of family attendant care. My bill would make it 112. So a family could get reimbursed for 112 hours a week.
So where I get confused with this portion of it is when a doctor is saying that a patient needs 24/7 care, and that care oftentimes with these patients requires two individuals because you're turning them every 4 hours, or you're suctioning out a tube so they can breathe every 2 hours, or things like that. I'm trying to understand the reasoning behind, you referenced earlier some bureaucrat in DC dictating care. This feels like the bureaucrats in Lansing dictating care instead of a doctor saying this is what the patient needs. And then there is a mechanism in place to detect anybody who might be trying to engage in fraud, and that would be the insurance adjuster. So what's the reasoning behind why the individuals in Lansing feel like they need to put a number on this at all when there is a system in place to catch any fraud like what you described?
So in the negotiations in 2019, I was not part of that. Okay. It was, all I can say is what I have heard from different individuals, legislators and such. The legislature was trying to make things concrete as to what is allowable services under the policy. I think we went too far, personally. As you stated, the court cases previous to our reform in 2019, the doctor's prescriptions, the doctor's notes, all led to it. But it seems that the whole goal of the 2019 insurance reform was to save money, to take the cost of our healthcare down, and the quality of the healthcare was not considered as much as the cost of the healthcare. And I think that was a very flawed approach, to consider the cost more than the quality.
So talk to me about, we've mentioned here there's the ivory tower where things get discussed in theory, and then there's the practical application. So we've had on the show here patients and their caregivers and their family members who are telling us their real world on the ground experience in trying to live under this new law. So what happens to a patient whose family is providing 24/7 care? Let's take the case of, there's a patient, his name is Clarence, and his family, he's a quadriplegic, can't feed himself, can't bathe himself, can't get out of bed, can't do anything. He's a quadriplegic. So somebody has to get him out of bed, put him in a wheelchair. He's cognitively all there. So he's definitely living his life with his family, and they're grateful to have their family member. But he requires two people 24/7, according to his doctor, according to him. That's what he's got to have. So in Clarence's life, under PA 21 and 22, and it sounds like also under your bill, that family is not going to be able to continue to provide that 24/7 care. So What do they do? What does Clarence do?
This is a discussion I had with a colleague. They were adamantly opposed to even raising it to 112 hours. I said, so they are going to have to hire somebody to come in and take care of them. Yes. They need to hire somebody to come in and take care of them. But it can't be their family member. So challenging people that this is the solution you want.
So they have to subject themselves to a stranger.
Yes, that is as the law is written, and it's, for me, it is challenging people's beliefs. Okay, you say you want this, but do you really want it? Okay, so family members will only be there for 56 hours to get paid. Okay, that's fine. So they're going to have to bring somebody from the outside in and pay them more. Yep. But they can't be their family member. Nope. Why? And then allowing them to try to tell you why they believe it should be that way. That has been how I've been going about combating it. Because when they hear themselves say, you have to bring somebody in from the outside and pay them, but you can't do the same thing for a family member, at that point, the arguments start to break themselves down, if that makes sense.
Right? They do to me as a non-elected official who's just trying to understand what's going on. I know that having, I've never been in a position that some of these catastrophic car accident patients are, but I've had surgeries in my life where, you come home from the hospital and you still have to have care. And I just, as a patient, especially a patient who paid for an insurance contract that I was supposed to have unlimited care from friends and family if that's what my doctor said I needed, I don't understand, because in the Republican platform, my understanding of it is that the contract is sacrosanct, especially a contract in the private world, a contract between a corporation and a citizen. The government needs to stay out of. And this feels a lot like government intrusion into a contract that is supposed to give that patient unlimited care, if that's what the doctor says they need. And now government is coming in and saying, well, let us impact your contract. We're going to say, no, doctor, the care has to be rendered in this way. It cannot be rendered in the way that the contract originally allowed for. It just is something that's hard to wrap my mind around in my understanding of what the Republican platform is really about with regard to protecting contracts. So my next question for you would be regarding,
if I can add
questions.
into that.
Many more questions, and I know we've been here a long time. So,
Rebecca, remember, the only thing consistent about Lansing is inconsistency. We say we trust the doctors until we don't trust the doctors. We say that contracts are, we shouldn't be interfering in contracts until we don't like the contract, and then we can interfere in it. So the only thing consistent about Lansing and about the government is a complete inconsistency about what we say until we don't like it. I'm with you.
That's true. You're right. Okay, so let me ask you, our last episode here, we shared the incredibly unfortunate story of two more patients passing away. They lost their care directly as a result of PA 21 and 22 because caregivers won't work. They cannot afford to work at the rates dictated by the existing reform of PA 21 and 22. And so these two patients passed away here in the past 2.5 weeks, who were otherwise for years perfectly fine at home. So direct result of new law, lost their care and died. Are your colleagues in the Senate and the House, your Republican leaders who helped get that law through, are they aware that people are dying?
Yes. And that the implementation of the fee structure in July 1 of 2021, and then seeing the real world effects of it has made a dramatic effect in how people see what they did when we voted for that bill. There's a group in Michigan called We Can't Wait, and they have been very active in talking with their legislators. They've been very active in being out on the tiles in the lobby of the House. They've been very active in engaging with their legislative staff and telling them this is what is happening. And because of that, because of the real world effects, many of the legislators have now been able to see with their own eyes and hear with their own ears from people that it's affecting more than just people. Many times in our world, whether it is, you name the thousands of bills that we deal with, any one of them, there's always individuals who cry wolf. Well, if you do that, it's going to do this to me. And then when you study it out, you think you come to the conclusion that they're just crying wolf. And so myself and my colleagues become rather calloused to the crying of wolf. And so, in my opinion, that is why there was not a fix before July 1, 2021. But now that there are real world impacts and individuals, providers are now coming forward and showing this is literally what is happening. Here are the bills. Here is how far we are in the rears. Here is individuals who have passed away, individuals who are now in the ICU at the hospital instead of having home health at home. Now that there are real world life situations and those people are talking to their legislator about it, that is really moving the needle. That is really moving public opinion inside of Lansing.
So, and I don't want to put you on the spot, so don't name names. I won't even ask you to name names. But is there anyone in that Republican leadership that helped pass this back in 2019? Do any of them still think it's a good bill?
Well, we have a lot of opposition from people who worked on it because it was some of their crowning legislation. It's the feather in their cap as they wrap up their legislative career. So that is what I have been working on the hardest, is to take those people who worked hard on the reform and not attack them, but show them where their bill should be tweaked in order to make it better.
I can't imagine anyone seeing it as a crowning achievement to have passed legislation that's literally causing people to die. That's not a crowning achievement. That's just my opinion, but I don't think that's a crowning achievement for anything. I think that's a massive moment to recognize I messed something up and be the big person and fix it. That would be a crowning achievement.
That's exactly how I am appealing. I do not want to impugn their intentions. I do not believe in any part of me believes that their intention was to eliminate healthcare for these patients and to kill them. That was not their goal. That was not their intention. They did not believe it was going to happen when the bill was passed. But here we are.
So in your bill, there's still a de-escalation of payment. So, in one section, It will go from $200 this year to $195 next year and $190 the next year, depending on which codes are being used. And this is, it's on pages 2, 3, 4, and 5 of it. So my question is, given the economy we're living in right now, inflation is starting, what's the reasoning behind let's pay people less every year. Why is that in there?
So my portion of the bill that I inserted is in bold. If you look at those pages, that was part of the negotiation before. That is basically going to, I can't speculate on it, but that is basically going to affect the acute care, the hospitalizations, more than it's going to affect our patients after they leave the hospital.
So the idea is that the acute side of care can withstand a lessening of its reimbursement every year.
I believe that was negotiated with them specifically.
Got it. Okay. That was my last question there. Okay. Thank you so much for coming on and explaining some of this. I know there's been a lot of talk and there's a lot of chatter, of course, in the community. Everybody's very excited that there might be some relief in the future. So it sounds as if there is a reason to be cautiously hopeful. Yes?
There are some pretty big meetings this weekend. And so I'm hoping, I'm cautiously optimistic.
That was Representative Phil Green from the Michigan State House of Representatives. His bill, HB 5698, seeks to address some of the more problematic elements of PA 21 and 22. With 57 co-sponsors joining him, he has a majority of elected officials in the House committed to passing the bill. At present, it is sitting in the House's Insurance Committee, whose chair is Representative Dare Rendon. From that point, the bill could either have a hearing in the committee or be brought out of committee directly by Speaker Jason Whitworth and ushered to the House floor for second reading, possible amendments, a third reading, and a vote. It is worth noting that the House Insurance Committee has not held a hearing on any bill since March 2021. As I release this episode to you, Representative Green and the Republican leadership from both the House and Senate are discussing his bill, auto no fault, and whether they will act when they return to Lansing. I'll let you know as soon as I know more. Thanks for listening to Silent Crash.
Follow and subscribe to Silent Crash, the quiet unraveling of Michigan's auto no-fault and the destruction of lives, wherever you listen to podcasts. For more information on what you've heard here and how you can help, visit silentcrash.net. Silent Crash is a production of the 1C Story Network. The show is written by Rebecca Seitz and produced by her and Rebecca Bond Tucker. Post-production services by Zischer LLC. This show is supported by the generous donations of concerned individuals via the Silent Crash GoFundMe effort. Learn more about the 1C Story Network at just1c.com. That's JUSTONEC.com.
The 1C Story Network, for the love of stories.